training. Topic here is workforce planning. The course is some extra bits that will fit within various different courses, especially the Wrapped Redesign course and the planning course. And this is session 4, the first one I've recorded, but it's session 4 because I got bored of overviews. This is the 7 R's of workforce planning. Really, this course is really going to be useful for those people who are looking to identify how to fill a workforce gap. Just start with a couple of standard slides just so you know who we are and the way we go about things. We are Carados, as it says there. We're a management training and development company. We're focused at the moment predominantly on workforce planning, but we want to build skills in general managers of any stripe in health and social care. So whether you're a primary care network manager, practice manager, community team lead, an acute service manager of any type, then hopefully these courses will be helpful to you. Specifically workforce planning, cost control, customer service, and then some general management skills. We also, as a company, work with Lancashire Care, actually it's Lancashire and South Cumbria NHS Foundation Trust now, and with Health Education England to provide and support the Wrapped tool, which is the Workforce Repository and Planning tool. I work with these guys who are the Wrapped team, based in Lancashire and South Cumbria NHS Foundation Trust. As I say, they provide the Wrapped tool. The tool itself is a modelling tool, can be used in the redesign and in workforce planning generally. And these guys will also be able to train you in modelling, which will be one of the courses later on. So that's who we are and how we go about things at the start of these wonderful blue slides that I tend to produce because my PowerPoint skills are not quite the same as my workforce planning skills. The approach to development we take is very clear. We're very happy to provide these courses for free. So one of the things we do like to do is provide tools and techniques. So either these courses or the Wrapped tool is all available, links at the end of this presentation. Because it's not just about providing these tools, though. You do need to have the time to be able to train, and you do need training and development in how to use these tools, many of which you can get by just taking time yourself and actually focusing on these online courses. But if you're going to do these, you do need to make sure that you are getting support for doing this within your organisation if you're going to take time up, because we find quite often that people will spend time on training, but it won't be linked to actually delivering anything. It won't be linked to what your organisation actually needs. And one of the things we find for development is you really need to have a good reason for undertaking workforce planning training, and it needs to be supported by your organisation. And finally, and most importantly, the point of the pyramid we've got there is the project. You need a reason to learn, you need a chance to practice, and you need something to prove success. So when we go through this training or any of the training, we'll quite often ask people to think about a real example, because it's only by working through a real example that you can really develop your skills in workforce planning. So I hope that's helpful. I just need to stress that every time we do these courses. So this module, I say the topic is workforce planning. It's sort of at the moment in the how to redesign workforce space, but can be used in various others. And it's part of the extra courses that we're running at the moment. We've got 5 planned: data, facilitating a workshop, which is important in redesign, process mapping, which is helpful in redesign, the 7 R's, and wrap modelling. And these extra courses are really there because if we put them within the main steps, it would make those courses very long. These are little pull-out areas that you can consider. And the one we're going to consider here is the 7 R's. And we're going to look at 2 things, really. One is typical workforce plan themes, and then we're going to go into each and every one of the 7 R's and strap in. There'll be lots of similar looking slides, but hopefully it's just a framework. There'll be a framework there for you to really think about how you can fill your workforce gaps. So that's why we're here today. As you can see, where it fits within the program, within the Redesign program at least, you can see we've got the 5 main courses at the top, and then we've got those 5 sub-courses, and this was noted as the Recruit, Retain, Retrain, Retrain, Return, which are 4 of the 7 S's that we consider. Cool, let's get into it then. So basically 2 uses. First one is you've identified a workforce shortage when you're developing a workforce plan. So if you're looking at your team and you can identify that you have a requirement for 10 physicians associates and you've got 5, you need to fill that gap. You want 9 nurses, you've got 3. You want 3 doctors, you've got 1. You want 8 social workers, you've got 2. Whatever it is, you've identified a workforce shortage and you want to think about how do I fill that gap. So that's the first reason. We look at this very much from a how do you fill a gap that way rather than how do you reduce numbers down. I guess we could come up with some more R's like redundancies or whatever, I don't know. But in reality, at the moment, the real trick is finding new people, and we have a workforce shortage in health and social care. So it's how do we find new people? How do we bring people in? How do we keep people? That sort of thing. So that's what we're looking at. The second reason you might want the 7 R's is if you're looking at themes for a workforce strategy. You might want to think about what are common organisation and system elements. I mean, yeah, certainly from a macro point of view, you might be looking at your system as to how do you fill a gap of 30 or 40 doctors or in certain specialties, or how do you fill a gap of 100 apprentices that you need, or whatever else, if you're looking at a system or region wide. But you might also be looking at ideas for what should form part of system interventions, and this list can be helpful for that as well when you're thinking of your options. So 2 uses for what we call the 7 R's, and I'll get into what the 7 R's in a bit. But before I do that, I just want to think about the typical workforce planning themes that you might face. So this is based on some very recent work we've done, but if you're looking at workforce planning themes that operate across systems in that second group, there are some pretty standard ones that are starting to come out in various different groups, and these play to all of the 7 R's. So first of all, there's a lot of redesign stuff you can do, which is the first 3 boxes on the left hand side. You can be optimizing demand, really trying to prevent illness or the need for intervention in your community, potentially using population health management information. And you can also build community resilience, both health specific, as in mental and physical health interventions in the community, but also non-health related, because theoretically things such as education, housing, employment, they actually have a greater impact on health than some of the interventions that we do in health and social care. So there's a whole piece around optimizing demand, reducing demand, but essentially optimizing demand, only making sure that people get into the health and care system when they need to, and making sure there's support in the community. So that's part of redesign. Then there's a massive amount of redesign in the approach going on. Primary care playing a pivotal health role, based on population health management information from systems such as Solace. And then redesigning services once primary care and community care is dealing with a lot of the people that come through what is now their front door. So that's based around working as one system, making sure you've got efficient standard processes and pathways, not bouncing around between organisations, making sure you're harnessing digital solutions such as care coordination and sort of map of medicine type stuff, AI, robotic process automation, virtual learning stuff, that sort of thing. Making sure you're optimizing your equipment and estates, building the right locations and the right stuff to help manage the amount of people you need, and making sure that any new and amended roles are embedded, which is particularly important, especially with the R's scheme going on, etc. Key part of redesigning services. Finally, given COVID, then recovering services are obviously a key redesign theme. Then you might also be looking at redesigning in priority areas. So you might just look at your areas and go, you know what, cancer is a major problem, which it is following COVID. Diagnostics is a major problem, mental health, urgent and emergency care and critical care, maybe social care, maybe you've got local fragile areas, maybe it's primary care, maybe it's community care you need to redesign. You can redesign priority areas and they often form part of plans. I mean, at this point, I'll introduce the bottom box there, which is address inequalities, diversity and inclusion. Absolutely critical. Massive arguments as to whether that should be in every box, and I would argue it is. Massive arguments that you've got to lift it out to make sure it happens, and I'd argue you have to do that as well, just to make sure you're really considering diversity, inclusion and inequality and equality across your workforce and your patients. And COVID has taught us that... as if we needed knowing that there isn't necessarily equality at the moment. We're not taking account of inclusion as much as we could, and therefore and diversity. Then therefore we need to consider that in every step. Then on the right hand side, you've kind of got a couple of other areas that are often focused. One is just addressing staff shortages in key groups. I mean, there's a few groups there that have come up recently, but it can be any group really. Medical and dental, there are a number of I mean, in general, finding enough doctors, but there are certain fragile services. Radiology, one example there, coming up time and time again. Nursing and midwifery, again, you could just say general, we haven't got enough nurses and we haven't got enough midwives. Again, there are a number of fragile areas, mental health and cancer being two critical areas at the moment. But then it could be any others. We're short of GPs, AHPs, psychologists, psychiatrists, scientists, any group really. AHPs haven't been mentioned. Yes, they have. So yeah, any of those groups, there's all sorts of shortages, again generally, and in key groups, podiatry for example in AHPs, and a whole range of others. And then in the bottom right hand corner we've got these kind of general and specific workforce interventions, and these are the ones that I think are typically the ones that fit within the 7 R's, and they are schemes that deal with recruitment, retention, they deal with retraining people, getting them back to practice at times, they deal with replacing people with digital solutions, they deal with redesign, return, and again people to return to work, and re-energizing. So typically these sorts of schemes will turn up in these system-wide workforce planning themes. So they're hugely relevant both to individual teams and to systems. So what are they? Well, there are 7 R's, and we've had to do some pretty nifty stuff at the end to keep them as to 7 R's, but you know, 7 R's are better than 6 R's and a W or whatever else, or 5 R's, a T and a W. What we've got are 7 different things you can think about, and you can use these as different things to think about in each of the groups. And all I'm going to do for the next 7 slides is to go through some examples in each of these areas. But the first thing you can do is recruit people. That's the traditional one. Bring them in. You can retain people you think are leaving. You can convince people who have left to return to work. Did a lot of that in nursing back in the early 2000s. You can replace the role entirely largely through automation, or just taking the entire task out because it's not needed. Robotic process automation is a great tool worth looking up. AI. Theoretically, you can put different staff in that role as well. You can retrain staff. Retrain other roles to do the role that you're short of. So that could be training nurses up to be specialists, for example. So there's various different things you can deal with there. You can redesign the role so that less of it is needed. Or certainly less of your shortage is needed. And also you can re-energize the pot of people that you've got. So if you've got a lot of people working on in an area, but the reason why you're short is that you've got high sickness levels, or you think you can improve efficiency, then there is an element of re-energizing that can be done. Appreciate that that's possibly not the best word, but it begins with an R, so you are stuck with it. So let's look at each of these in turn then, shall we, in terms of what things might be considered. Now, I suppose I'm not going to go through each one necessarily, but we'll talk generally about each topic. So recruit. Traditional one, at the moment we've got 6 people, we want 10 people. we can just get some adverts out and we can recruit people. And typically, we've seen all sorts of typical schemes. You've got national recruitment, so you can try and find people within the country. Again, you can link in with national schemes, or you can just do it yourself and get an advert out there on internet, and off you go. And international recruitment's been a big one. I think COVID's going to reduce that. I think Brexit's going to reduce that. It's been harder to get people into the country, and there's been an increased demand for healthcare staff, so I think they're going to be harder and harder. If you are going to bring people in, then you need to be able to keep them. I have seen groups of stunned looking people wandering around hospital sites, wondering what they've let themselves in for in the north of England on a rainy day sometimes. So it is about making sure that you are, once you have recruited those people, that they don't immediately want to leave, and you want to be able to make the most of them coming in. But national and international recruitment are, of course, mainstays of recruitment. Very much recently, apprenticeships, bringing in more apprentices. Then there's a couple of other things you can do around trying to bring people in. Obviously, getting around the schools and the colleges and the universities, milk rounds, etc., if they still happen, and building awareness amongst those people. You want to get people to get into health and social care largely, and into your organisation. You can cover costs of tuition, certainly in nursing, for example. I'm not sure it's completely agreed quite what the impact of removing the bursary is, but it was bad to start with. So covering the cost of tuition, and then some sort of locking in, for example, of people would give you some recruitment. But then there's a whole lot of other ones as well. So NHS is great place to work type schemes. Yeah, they're coming up a lot. Or great place to live. If you want to get people to move to places where it's traditionally difficult to find skilled healthcare workers. Referral rewards for staff who refer people in that stay for a certain amount of time. Golden hellos, theoretically, from a financial point of view. I've not seen them being used, but they're possible. And then a couple of other ones just to flag. One is around trainees delivering service. So, I mean, one thing you find is that quite often training can be a long process. So if you can get people starting work before they've finished their training, albeit part-time, then that might be an option. We certainly saw that in COVID, but we are seeing that happening to sort of deal with the fact that you have very, very long training and then long careers. Actually, you can do a bit of merging those a little bit. And then the final one is representation analysis, playing into the whole thing around diversity, equality, and inclusion. We can at times recruit from restricted pools, and having a look at how we can recruit from a wider pool to increase the likely pool of people that we can bring in, to increase that through diversity. And that could be through any of the factors on the Equality Act. So you might be considering, are we targeting certain racial groups, but also age as well, making sure we're targeting the right groups there, different cultures, etc. So it's certainly well worth a consider. So there's lots of things you can consider from a recruitment point of view, which is really typically about how can we get more people in who are already good at this job in through the door, or how can we get people in that want to start these careers. Obviously, built on Recruit, if we're bringing in people that are not necessarily trained, then we are going to have to do more training. So retraining people in one role to get to a different role is another key one. There's a lot of work done around making sure people are operating at top of grade. It's not one I'm a massive fan of. Having done this early in my career and created roles where people were just working at their top of grade all the time, it became quite stressful for the people involved. I think it was particularly radiology in that particular case, and you don't always want that happening. So roles can't always rely on everyone working at their top of their grade. But it is certainly something to think about, is how do we get the best out of the people that are there, and how do we get other staff doing the parts of their role that could be done by other staff, and certainly the ones that this staff group don't want to do. Obviously, there's a move from getting people from unqualified to qualified, and also the creation of enhanced roles where possible, where you've got great staff and you can enhance their skills further so that they can operate to deal with some of the stuff that that a different grade, I'm going to say the grade above does, but the different grade is able to do. So, nurses can pick up the roles of medics and that sort of thing. I suppose while we're thinking about retraining, it is certainly worth considering the potential of staff in areas such as primary care when they come in through the door, and how you can utilise the skills and the attitude of staff that have come in through the door, maybe to start in reception, as to whether you can move them into other roles such as care coordination, into actual training in clinical roles of some sort, training them in social resilience, or developing their skills to train them to be better and better administrators. These are also things to think about in terms of how do you focus on a staff member and every staff member when they join your organisation, and how you can build them to fill the gaps that you're going to need both now and the future. So retraining is an important one. Third one is return, which is really about getting people to return to work. So we've let them go. They've left for all sorts of different reasons, or they are leaving. There are a few things to think about. One is options for disabled groups. Disabled may or may not be the right term there, but the key point there is that if somebody is leaving because they can't stay in work for whatever reason, a physical disability, a mental disability, or whatever else, building plans around those is an option. How can we keep their skills, or at least part of their time, part of their skills, by doing different things with those individuals to meet their needs? That'd be great. And that kind of links a little bit with the one-to-one planning with leavers. If people are leaving, how are we keeping in touch with them? Why are they leaving? Can we keep them somehow? But also, how do we keep in touch so that they may want to come back? What if they're leaving? How are we going to keep in touch to say 3 months' time, 6 months' time? Is retirement really everything you wanted it to be? Maybe you can come back and do a day a month or whatever. These are all options, day a week or whatever. Another one on that list, not always a popular one, it's one now I'm putting it down on the list, is the specialist sort of back to the ward type stuff. So if you're short of people delivering nursing roles or any other role, and you've got lots of specialists doing other things, if you could get them to a day a week back doing the sort of the basic stuff, that might help you fill the gaps. It might also disempower those individuals. It might not. It might be great for them. You have to keep an eye on these. I'm not saying any of these are risk-free, but a kind of specialist back to the ward thing works quite well. Portfolio careers, big one. We lose a lot of people because, especially for some of the sort of demographic groups, portfolio careers are becoming more and more important. And if we're just offering 5 days a week, maybe that's why people are leaving. So in advance, finding out what people want, part-time work in portfolio careers, may actually keep your staff around for longer. And then finally, the good old back to practice schemes. We see this when we desperately need to do large-scale recruitment, nursing. Obviously, we found a little bit around COVID. But there are a lot of people out there who will have been pharmacists, nurses, doctors, GPs, social workers, people out there that are now doing other things. And if we can make it attractive enough, we might be able to get these guys back, get them retrained and get them working again, maybe as part of a portfolio career. All of these things have risks. I remember the back to practice scheme in nursing meant there were some pretty specific staffing patterns that were set out, which made it difficult to do nurse rostering. So you've got to be a bit careful you don't overdo it when you're getting people back in. But at the end of the day, these are options for getting people to return to work. Retain. Now, retain's an interesting one because, of course, it relies on the fact that your planning has already thought about the fact you're going to lose people. So at the moment, you might not be short of anybody, but you're expecting in 3 years' time that you'll be 10 short because they will have left, they will have retired, or something else. What are you going to do to retain people? Well, you can bring your turnover rates down through good leadership, and there's no doubt about it. It's absolutely critical. People tend to work for people. Even where money is better elsewhere, you can often keep people because they enjoy being part of the team and they love the leadership they're under. the few things to think about. One is proper appraisals every year or every 3 months or every month or whatever else, however you do it. But lots of people don't really get appraisals. They don't get praised. They don't get told they're doing well done. They don't get developed or their skills appreciated, and they leave as a result of that. So making sure there are proper appraisals with a proper system for that is a great option. Leaver interviews, if people are leaving, really finding out why they're leaving and making sure they're done by independent people, find out what the problems are. I've certainly left a number of jobs in my time and not had a leaver interview. People don't want to know why you're leaving in some respects, which can be a mistake. So really understanding what it is and pulling the intelligence from those leaver interviews and addressing concerns raised can be absolutely critical. And again, portfolio careers, keeping people from wanting to leave can be critical. And again, that one-to-one planning with people. In this particular case, one-to-one planning with retirees. If people are leaving, sitting down with them and working out, okay, you're leaving. How are you going to come back? You might not want to leave. Sorry, in this particular, rather than come back, you might not want to leave. You might want to do 3 days, 2 days, 1 day. You might be able to do other stuff. That gets done a lot with good staff already. It's an option. The key thing, though, really, of all that stuff there is working with people. At the end of the day, if you sit down with people and you say, right, guys, what do you want from this job, and how does it best meet? How can we best meet what you want to achieve? Then, and that's a combination of sort of appraisals and can be done as part of the appraisal process. Good leadership. But these are all schemes that can be put in place where we are training people, our leaders, in how to do this stuff, and we are monitoring that they are doing it, and we're addressing stuff centrally. So options there under retention. Re-energize. I've moved this one to 5 for some reason in this list, but yeah, a whole lot of stuff you can do. So a lot of this is about sickness and wellness. But again, at the heart of it is leadership there. You need good leaders. Good leaders will help make sure you've got a great team. So leadership, training, and clarity around expectations and proper talent management and all that sort of stuff. Then leadership's a key part of this. But then there are all sorts of various other things. Mental health improvement, physical health improvement, all that sort of stuff. Is critical. Putting wellness at the heart of what you do, having it as a real corporate pillar, and really driving it and focusing on the wellness of your teams is absolutely critical. At the end of the day, a lot of staff become patients, and this is helpful from a demand management point of view, if nothing else. But it's absolutely critical from a staff point of view. You can also do stuff around sickness itself, so making sure there's proper plans for long-term sickness, so you're really working out how you can get people back at the right time rather than perhaps leaving them at home longer than they would otherwise be. And then also targeted sickness level reduction, which is always an interesting one, but obviously using Bradford Index type stuff and monitoring sickness, proper return to work interviews, monitoring by team, all that sort of stuff. You can do quite a lot around targeted sickness level reduction. A lot of that was happening back in the turnaround days in the 2000s. These are all very interesting. I think the thing is, of course, is that this re-energizing stuff, it can't just be about gym memberships, as one person once said to me before. At the end of the day, re-energizing people is about, again, good leadership and understanding what people's requirements are. But it's an area you can focus on. Redesign is the big one. We've got a whole course on redesign, so I'm not going to go into too much detail on this, but there are a whole host of different schemes that fit within redesign. Putting expertise early, at the front door of stuff to really drive stuff differently is a great principle to follow, to think through. Combining roles where you can to reduce the number of silos that you've got can be really, really good. Reducing travel times, introducing new roles, introducing new digital equipment, digital technology and new equipment. Streamlining your estate, building the right buildings, making buildings efficient for staff. Combining support to patients so that only one person sees them and not 25 different people. Having multidisciplinary teams, both in primary care when they're really looking at is it GP led rather than GP delivered? But also working within hospitals again, where it can be clinician led rather than clinician, or medically led, whatever else, rather than medically delivered. Where you can really consider, everyone can get together, consider what somebody needs as a complex individual and move them on, rather than everything being seen in silos. Streamline the number of organisations so people don't get lost between them or have to have work redone between them. That can be organisations, can be teams, and reducing handoffs within the organisation, so fewer and fewer teams, really concentrating on those boundaries between child and adult, or between level 1 and level 2 and level 3 and level 4 of intervention or whatever. All of these can be great principles for redesign. At the end of the day, of course, redesign, we've been talking about it in the courses and we'll talk about it in the courses. It's about actually saying, right, how do we look at this entire system and redesign it, and redesign the workforce to meet what should be a change level of demand from patients and service users, and what should be a change level of need to intervene, because we've changed the process to be more and more efficient and focus on better outcomes for patients. The final one is replace, and it kind of fits a little bit within redesign, but you can actually just look at replacement. A few things: self-service or self-treatment. So you can see that in terms of mental health. Is there more that we can do to reduce the need for staff by reducing the amount of people coming in through the door? So can people self-service? Can they self-treat? Can they self-refer to things? Can they go straight to physio, for example, without having to go through a different, an admin or a GP function or whatever? There's a lot of stuff you can do around that. You can also look at that in terms of kiosks, replacing reception, if you like. At the end of the day, of course, you have lots of different patients and service users, and they won't all be happy talking to a robot. But anything you can do around replacing the need for as many staff, if not all staff, is always one of the options. Linked to that is about volunteer and system resilience. People with lived experience, volunteers, carers. At the end of the day, our health service and social care services rely on unpaid people doing work in the community, obviously, always has done, relies on people doing stuff themselves to an extent, and the more of that you can build, it can be great. And of course, in certain areas such as mental health and physical health, the more you can engage people in that voluntary work can actually help their own health as well. So some of the system community resilience work being done in places like Frome and Fleetwood. I'm sure there are many others. Some great examples there of building sort of resilience and getting sort of a volunteer army to do stuff. Then you can replace things with other things. So artificial intelligence wouldn't necessarily remove the need for people like radiologists, for example, but it can certainly do some pre-work to help reduce the amount of time that a radiologist would need to look at a scan, for example. There are a whole host of different things you can use artificial intelligence for. It is worth considering what can be replaced, what can be streamlined using technology. And then another one, robotic process automation. Robotic process automation is happening quite a lot. It helps in all sorts of processes, especially administration processes. It's a little bit like, I'm not going to describe this very well at the moment, and you can look it up on the internet, you're all grown-ups, but what it enables you to do is it can often work out what sort of keystrokes you're using, what happens once you've done something. I suppose you could call it like a bit of a mini AI in that regard, so that it can start to automate tasks that you do. So that once you, for example, it will notice that if this comes in with these conditions, then you can just move it into this area straight away. This action will happen immediately afterwards. And you can write a number of scripts that can essentially reduce the need for administrative intervention considerably. I know in the organisation I used to work in, I think they were saying there's something like 40,000 scripts running across their large global organisation. There you will see more and more of this as obviously as technology continues to improve. So there's a whole lot of technology response you can do as well. So that's really it. That is the 7 R's. It covers all those different areas. I'm sure there are many others you might be able to introduce, and I'm sure I could crowbar them into one of my 7. But that's the model we use for identifying what might be the responses to a workforce gap. So what are your next steps? Well, don't forget, you can always register to the RAP tool if you haven't already done so. You can buy the Bumper Book of Health and Care Workforce Planning, which covers this and many other topics in the world of workforce planning, available soon in all good bookshops or possibly just on Amazon, depending on how things work. You can visit the RAPT website itself for information. You can visit the Health Education England pages for more information on workforce planning tools and techniques, or you can visit my website, the www.carados.com. You're already hopefully on the YouTube channel at this point, and at some point there'll be a link between the Carados website and the YouTube channel. What might you be doing next? Well, you might be doing Wrapped Redesign. You might want to consider Wrapped Hub, Wrapped Frontline, and one mentioned there, Wrapped Plan, depending on which one you are in the middle of at the moment. Or you might just want to continue one of those courses. But they are all steadily being put onto YouTube, so hopefully when you watch this, many others will be available. Those are the next steps. Thank you very much for your time. I hope that's helped. Look forward to seeing you on another course. All right, thanks very much.